So next we move on to the symposium of InspireMD, and please stay seated because afterwards we also continue with the carotid session. So as we all know, the practice is changing everywhere and we get newer and newer devices, and I think InspireMD really plays a key role in there. So it's really my pleasure to ask one of the persons who does loads of research in this area and has loads of expertise, Piotr Musalek, and he'll be talking to us about the role of MicroNet-covered carotid stents in the post-CREST-2 world. Piotr, the floor is yours, and if you want to, we can interrupt you, or you prefer not to?
You are very welcome to interrupt.
Thank you very
so much, Isabel. It's exciting to be here. It's also exciting for me to discover less modest Richard. Richard, I have to confess I've not read your editorial, but now I certainly will. To Dr. Schneider, the study that you mentioned by Rothwell, in fact, they screened a lot of patients, but they included only about 100 patients. And it's not a natural history study, because when somebody was symptomatic, they were getting CA. So it's very often misinterpreted, the Rothwell study. So post-CREST carotid artery stenting, where do we go from here? What I would like to convince you is that MicroNet-covered stents may deliver superior results than the results we've seen in CREST-2. But before we get to this study that was already beautifully mentioned, let's start with our patient today. So the patient is a 71-year-old lady with right hemispheric stroke 11 months before. The stroke symptoms resolved nearly 100% by now, and she's not had any new symptoms over the last 10 months. This is her brain. This is her duplex. You can see near occlusion of the right internal carotid artery. There's also CTA was also done, collapsed artery of about 2 millimeters. The patient meets CREST-2 criteria. Agree?
Maybe we should ask Caitlin and Peter, because I think they were part of the CREST-2.
Yeah. This is type 2 arch. Yeah. So the patient could be treated with either intervention in CREST-2.
The key thing about CREST-2 inclusion was that there was no real consort diagram. We have no idea how many patients were screened. I'm going to guess that 1 out of 20 or 1 out of 30 got admitted. So the question is, what about all the rest? And then secondly, I kind of mentioned this before, and Caitlin mentioned the opposite end. That is, she was reluctant to randomize a trial with a true progressive lesion, and I was reluctant to be in the trial because I didn't want to operate on people that had only moderate lesions.
And the other way around also, you would not want to leave someone at high risk without intervention. So my bet is that CREST-2 included less severe lesions that we treat in everyday practice, often.
Piotr, the point I was making is the absolute risks will not be the same in CREST-2 as in normal routine practice, but the proportional effects you see probably will be.
Thank you. So the daughter is a good MP. She visited 3 other cardiovascularization centers, and here's what they heard. This would require surgery, but there are risks. Patient is asymptomatic. I'm rather not keen to perform it. The second sentence, they said both surgical and percutaneous fix could be considered, but there's risk of stroke and even death with intervention. There's also a risk of bleeding to the brain, only if you really, really want. The third sentence said things are okay now, your mom is asymptomatic, but after the procedure she can be paralyzed. You have to make the decision and take the consequences. So she happens to be actually the MP I voted for. I didn't know that before I saw her in my office with the mother. And now they come to me and they say, please help us make the decision. We do not want mom to have another stroke, definitely. We would rather not have surgery if stent is possible. So will you do it? But we don't want complications. Please make this safe. What do you do? I say, can I have a different patient, please? Yes, but this is life, yeah? So I thought I need some evidence to make more evidence to make my decision. I requested, and we discussed this yesterday, the perfusion scan that showed hypoperfusion of the right hemisphere. So I thought I am more convinced to go for intervention in this lady. Of course, I told the daughter and the patient that there's no zero risk procedure. How to do this maximally safe? Nacho.
Hang on, Nacho, hang on. We don't want to miss these lovely words.
I will try my best to combine the best access, the best neuroprotection strategy, and the best stent as possible.
Fantastic. Dr. Schneider, how would you treat this patient?
My gosh, you're really making me run today.
I agree 100% with Nacho, and this has come up over and over. I think all these procedures are complementary. Whenever I can use flow reversal, I think that's the best option. That's the only thing I would add to what he said.
That's the big connection and love between us.
For me, that's a TCAR.
TCAR patient.
Eventually, we'll have transfemoral flow reversal, and we'll be friends again, you and me.
We are still friends. I'll show you transfemoral flow reversal. So proximal protection by transient flow reversal, that was my choice, and the stent that would exclude the plaque in this patient. This is what the lesion looks like. You can see it's a really tight lesion. There's organized thrombus there. We don't know the component of the fresh thrombus, but definitely this is a patient that can get another stroke. The patient is part of the paradigm study. We are not excluding any patients, and also the study does not have the exclusion criteria of the CREST-2. This is the cerebral flow before. So what I did is I reversed the flow with the MoMA device. You can see here crossing the lesion, pre-dilation, then placement of the MicroNet-covered anti-embolic stent, optimization of the stent with 4.5, then 5.0 short non-compliant balloon, and this is the final result. This is the cerebral flow. This is the cerebral perfusion after the study. This is 6-month follow-up. So we can do a safe procedure today. We can seal the carotid lesion. We can restore normal flow in the artery to the brain. We can do full endovascular reconstruction, and I can assure you that this patient will never have a stroke from this lesion. She may get a stroke for a FIP or for another
Doctor,
reason.
can we interrupt? Optimization, what is this? Because I know not the whole audience may know that. And there's also a question from Nacho.
Quick question. Yesterday we discussed about pre-dilatation and post-dilatation. Could you comment on your pre-dilatation and post-dilatation strategy on this patient?
That management was consistent with what we routinely do. You can see here predil with, I think this was 3.0 balloon, then stent placement, and then post-dilatation with, I'm sorry, going the wrong direction. And then post-dilation optimization of the stent. So full optimization of the device, yes? Not to leave the stent malaposed, not to leave residual stenosis. I think you'll agree with me. The artery did collapse. As you will see, it will grow with time. But this is a fully optimized procedure, yes? Not leaving residual stenosis, again, not leaving malaposed stent.
Piotr, I got a question. Your sort of evidence that you put together for your decision. Those who've looked at the program will notice that there's a debate this afternoon. I've never heard you mention the word plaque.
Sorry,
Plaque.
in what sense? The plaque, yes,
Yeah,
yes, we're
yeah.
talking about plaque characteristics, yes.
But we'll do that in the debate this afternoon. So everybody who wants to know more about plaque and the debate between the two of them, come and see us.
Alison, I mentioned that the plaque is a thrombus-containing lesion, yes? So this is really, again, and that convinces me to intervention in this patient, yes? There's organized thrombus, but there's likely to be also fresh thrombus there. So yes, plaque also comes into the equation, and as Isabel mentioned, there is a debate on this later on today. So we will not be discussing the part of CA in the CREST-2 trial. These were really two separate trials. Both interventionists and surgeons organized the trials they believed are relevant to their clinical practice. The 31 people was mentioned by Richard as a number needed to treat. What I would like to point out is that generally the patient were receiving good medical therapy, except that stenting arm, where the medically treated patients received better pharmacologic therapy than those stented, yet there was a clear benefit of stenting. So the question today is, can we, the
Doctor,
stenters...
I have another remark here. I'm sorry, I didn't spot the gentleman.
No, where are you?
I'm sorry to interrupt you. You showed us perfusion scans in the preoperative workup. Do you use transcranial duplex scan, or is it a useful tool in the preoperative workup, in your opinion?
You mean to look for a spontaneous embolization from the plaque? No, we don't use it in clinical practice. No, we don't see this well standardized. We do not have people who can do this reliably. There's data from many years ago showing the embolism from the plaque. I don't know how long you would have to monitor, you know, whether the plaque embolizes or not. No, we don't use it in clinical practice. It is in the guidelines, but that's not what we have found applicable to our clinical decision making.
Thank you.
Anyone using transcranial Doppler?
And can I say something as well about the TCD? Older women, often they're not inducible.
But if they have, you could actually say something about the cerebral autoregulation. I think that's very important also when you want to answer the question about complication risks. So if you do a transcranial Doppler and look at the vasomotor reserve capacity, then you can have some impression also on the complication risks. So,
Can you elaborate on that? In what way?
so then if you have no autoregulation anymore, so you have a complete vasodilatation in your middle cerebral artery, then it might become really dangerous.
So risk of hyperperfusion, you mean, and bleed,
hyperperfusion
yes?
syndrome, you have to take care of the blood pressure, so that actually help you in assessing the complication risks.
Thank you.
So should we ask the audience who uses that? TCD, routinely?
Yeah.
In our team, we have neurologists who use it routinely, and we take it into account in a decision-making for an intervention for the carotid artery.
I think it's got easier. When I used it back as a researcher, it kept falling off. It was just such a pain. But now you've got these bicycle helmets that you wear, and it's much easier.
So Richard, where does this fall in CREST-2 data, your evidence-based, you know? TCD was not there.
I think, as the show of hands showed, it's a relatively niche investigation. Maybe it should be used more, but yeah, well, it wasn't included in routine practice and therefore wasn't included in CREST-2.
Yeah, I think we need people trained in performing it. Right, so the question to me is, can we, the stenters, do better than CREST-2? Can we reduce periprocedural stroke and can we reduce ipsilateral strokes long term with appropriate plaque control that would reduce number needed to treat? I'm repeating this slide because people came up to me yesterday, they said they actually like it because this is how vascular surgery feels about CAS as a treatment, not as a cure. So what I want to propose to you is that with second generation stents, we can actually cure the artery and cure the patient. So can we reduce this rate here of periprocedural complications further? And can we reduce some of those events to really knock down the curve further? There is some incidence if you look at the recent trials. The trials listed in the bottom, they actually show procedure risk about 1% or below 1%. So that's already what would bring the CREST-2 curve down with plug insulation with the MicroNet-covered stent.
Piotr, just to interrupt, those are quite selective registries, aren't they? I mean, the more all-comer data does suggest a slightly higher rate of CAS-related procedural stroke.
I don't know, Richard, what data you talk about, but in fact, we are running an all-comer study with monitored data externally. So this is totally unselective data. What is the data for, you say, unselected patients?
It's the VQI and the German Quality Assurance,
yeah,
which captures everything.
Yes or no? I would suggest no, because if you look at VQI data, I was looking at it the other day, it's actually self-reported results, and there's at least 3 papers that say, I don't know if you've read those papers, that the real patients have higher risks than the patients included in the VQI data set. So you may or may not include your patient in the VQI, depending on how your procedure goes.
Sure.
And the data is not monitored. I'm talking about monitored data. So the CGuard trial, the paradigm study are externally monitored, and the data are adjudicated by a critical event committee. So can we do better by reducing those post-procedural events? You can see 40 to 80% in captured, in large series in CREST-1 are the events that occur after the procedure. So if you can eliminate those events, your curve would be knocked down.
Peter, can I interrupt you really quick?
Sure.
I want to just correct one thing about the VQI, that you don't get to pick which events you put in the VQI. If your center is part of the VQI, you report all things that happen. The challenge with the VQI is that not all centers are part of it.
I've seen 2 or 3 papers about patients included and not included in the VQI. Published in, I think, JVS, one of those.
That is not supposed to be true.
It shows that the risk event rate is higher in the patients not included in the database.
True, but that's because not all centers are part of the VQI, so only large academic centers mostly contribute.
And also...
But it's not monitored, yes?
The events are...
Intermittently, it's 10% of sites are audited on site here.
10%, so somebody comes and verifies, okay.
Yeah, so there's this recurrent auditing that does go on, but it's not the same as an RCT. It's not the same as a clinical events committee and DSMB.
Probably the best you can do. It's either the conflict, Richard, about large scale of the data and better controlled smaller samples, yes? Okay, thank you for this clarification. Still 90% of data are not audited in VQI.
Oh, you don't let it go.
Okay, let's just
no, I'm
continue.
just thinking loud, you know?
Not every site is audited every year, but every site will also be audited on a rolling basis.
For
Sure.
all data or for some data?
Piotr, 36 seconds left.
No, I'm sorry. We've been talking a lot, you know. So there's a randomized study that Richard mentioned about a CREST study stent versus MicroNet-covered stent. And this study, Richard calls it small, but the study is appropriately powered for the endpoint of DWI cerebral embolism. Professor Holliday raised the issue of, DWI lesions, do they matter or not? But there's 2 large series, including a series from neurology and from Alexander Lansky in TAVR patients that show a relationship between the number of and size of lesions and the risk of clinical stroke. So yes, DWI is a surrogate for the risk of stroke, and you can see profound reduction in stroke risk in the load of DWI lesions to the brain with the MicroNet-covered stent, and that did translate into a suggestion of clinical benefit at 12 months. Now the database is more than 5,000 patients. I just want to touch on the CGuard's FDA trial. That's another study that was published last week. Here we enrolled 316 patients, 25% symptomatics. That was predetermined by FDA. More than 40% diabetics, so really sick patients in this study. Neuroprotected procedures, mostly distal filter. You can see less than 1% death stroke MI by 30 days. These are the patients we did include in the trial. Richard, I know you're behind, but I will continue. And now I'm taking both ways. These are not the patients you would normally include in the clinical studies. Yes. And let me show you, these are the results. This is the publication in JACC Interventions. Thank you so much. I will keep it going. And this is the best ever results in the, you won't shout my mouth, I'm sorry. This is the best ever results in an FDA study. Let me just finish. And you have here the TCARs, you have Road Saver, you have NeuroGuard, you have different types of interventions. And these data are consistent between the 3 studies, CGuard's Paradigm 500 and the TopCard study that we hope with Isabel will be soon out in JVS. You can do transradial, that was discussed yesterday. You can do TCAR. You can do advanced imaging that really helps you understand that you have fully eliminated the plaque, you have cured the patient, you have cured the vessel. The OCT study is ongoing. We are nearing inclusion of 50 patients. We'll be able to give you the results next year. ISR less than 0.5%, no instant thrombosis, optimization we discussed. And that's what I just want to submit to you as Dr. Ratner is here. I think it's time to forget the 6 and 3% threshold. It's time to forget the 4 and 2. The new performance bar is about 1%. So if you do worse, be careful. You need to improve your outcomes. You should do below. We can do better. This is long-term data. This is 5-year data. And I really want to finish. And thank you for your attention and for not taking out from here. Thank you.
Thank you very much, Piotr, for a fantastic overview of a lot of data.